Hi everyone, welcome again to my YouTube channel. Our topic is all about chest CT protocol and imaging procedure. Chest CT protocols and imaging procedures. CT imaging of the chest present unique challenges because of the continuous motion of the heart and vascular structures. Improvements in temporal and spatial resolutions that have been realized as a result of multi-detector row CT have been particularly valuable in thoracic imaging. This technology allows the entire thorax to be scanned with thin sections during a single breath hold, making consistent high-resolution imaging possible. General thoracic scanning methods. Most thoracic protocols are performed while the patient lies in the supine positions on the scan table with arms elevated above the head. Okay, the patient is supine positions with a arms elevated above the head. In a few instances, primarily high-resolution CT protocols of the lungs, additional scans are obtained with the patient in the prone positions. Using the shortest scan time possible helps to reduce artifacts created by the respiratory motion. Okay, prone position. Whenever possible, a scan of the chest should be acquired within a single breath hold, as this will prevent misregistrations that may be caused by uneven patient's breathing between scans. The thorax has the highest intrinsic natural contrast of any body part. The pulmonary vessels and ribs have significantly different attenuation values compared with the adjacent aerated lung. In most adults, the mediastinal vessels and the lymph nodes are surrounded by enough fat to be easily identified because of this intrinsic natural contrast. Intravenous iodinated contrast administration is not necessary for all thoracic indication. For example, a scan done for screening, detections, or exclusion of pulmonary nodules or primary lung diseases such as emphysema or fibrosis are typically done without IV contrast administration. The use of the IV contrast materials is typically requested by the radiologist to differentiate vascular from non-vascular structures, particularly lymph nodes, to evaluate cardiovascular structures by seeing inside of these structures, and to further characterize lesion by observing their pattern of enhancement. The demarcation of the esophagus and the gastroesophageal junction can be improved by giving the patient an oral contrast agent, most often a barium suspensions, shortly before beginning the scan, but is not necessary for most thoracic CT examination. CT of the airways. Airway imaging is routinely performed at the both inspiration and expiration. Technical parameters used for CT imaging of the airways include the use of thin sections 1.25 millimeter or less, a fast acquisition that allows the entire lungs to be scanned during a single breath hold, optimal spatial resolution, and the use of the post-processing techniques. Overlapping Z-axis image reconstructions of 50% is typical. Neither IV nor oral contrast media are routinely required. IV contrast may be used in cases of airway tumors. Airway imaging is routinely performed by both inspiration and expiration. CT is generally accepted as the best imaging technique for assessment of disease of the central airways and is most commonly used to look for narrowing that may occur in patients who have been intubated in the past. Applying post-processing techniques such as volume rendering may be referred to as CT bronchography. Virtual bronchoscopy is accomplished with similar post-processing techniques, but it is different in that it offers an internal rendering of the tracheobronchial walls and lumen. High-resolution CT. High-resolution CT of the chest is used for the assessment of the parenchyma in patients with diffuse lung disease such as fibrosis and emphysema. This is the high resolution of the chest CT. Okay, this is the example of conventional scan of pulmonary lesion surrounded by a zone of edema or an infiltrate. This is the pulmonary lesion. Like airway imaging, high-resolution CT protocols use thin sections 1.5 mm or less, a fast acquisition to reduce motion artifacts and optimal spatial resolution. In addition to the thin sections, spatial resolution is optimized by the selection of an edge-enhancing algorithm, such as bone algorithm, and a display field of view that is just large enough to include the lungs. In some situations, high-resolution CT protocols are incremental, meaning images are obtained with an interval of 10 mm or more between slices and only approximately 10% of the lung parenchyma is scanned. This technique is intended to provide representative areas of lung disease. However, because evidence of some types of diffuse lung disease may not be uniform in distribution throughout the lung, this method of sampling may result in characteristic foci of disease not being imaged. Some high-resolution CT protocols are designed so that only a representative 10% of the lung parenchyma is scanned. Other protocols called volumetric high-resolution CT use a helical mode to, to acquire images of the entire lung. More recently, as multi-detector CT scanner have become commonplace, the technique known as volumetric high-resolution CT is replacing the high-resolution CT axial protocols. Volumetric HRCT protocols use a helical mode to acquire images of the entire lung rather than representative slices. Because these helical protocols cover the entire lung, they result in a more complete assessment of the lung. Lung nodules that could be missed between slices in incremental protocols are not missed with volumetric high-resolution CT, and the central airways can be evaluated at the same time. In addition, they allow post-processing techniques such as maximum and minimum intensity projections reformation. Although there are clear advantages to the use of volumetric high-resolution CT over an interspace technique, the increased radiation exposure is a consideration. Many volumetric high-resolution CT protocols decrease the tube current MA to reduce the radiation dose. Many high-resolution CT protocols, both volumetric and axial, include more than one series of scan. In all patients, there is a gradual increase in attenuation and vessel size from anterior to posterior lung regions owing to the effect of gravity on blood flow and gas volume. In addition, there can be atelectasis in the most dependent lung, the side touching the CT table, that can mimic or hide lung disease. For HRCT or high resolution CT studies, prone images can help to differentiate actual disease from densities owing to effects of gravity that mimic diseases. An additional series of prone images can help to differentiate actual disease from what is not. Expiratory scans are used to look for areas of the lung that do not empty or get smaller, which is indicate a small airways disease. When the lungs are fully expanded, the contrast between low attenuation aerated airspace and high attenuation lung structures is maximized. Therefore, high-resolution CT protocols are routinely obtained at full inspiration. However, expiratory images are useful in many instances. For example, expiratory images better depict bronchiolitis and air trapping. The density graduate from the effect of gravity in more pronounced on expiratory images. For these reasons, high-resolution CT protocols may include three series of scans: inspiratory supines, and inspiratory prone. In volumetric protocols, only the inspiratory supine series is done in helical mode. The additional images are done in the representative axial fashion to reduce the radiation exposure. This is the thoracic protocols. Routine chest. Example of the clinical indications: infections, mass, emphysema, evaluation of abnormalities discovered on chest radiographs, evaluation of known or suspected congenital thoracic anomalies, or evaluation of trauma. Scouts, AP and lateral. Scan type, helical. Start location, just above lung apices. End location, just below costophrenic angles. Note for known suspected lung cancer and just below adrenal glands. Breath hold, inspiration. IV contrast, 80 milliliter and 3.0 milliliter per seconds. 50 milliliter saline flash. Scan delay, 35 seconds. Oral contrast, none. Note for known or suspected lung cancer, give 16 ounce barium sulfate just before examinations. Display field of view 38 cm, optimized per individual. Scan field of view large body, algorithm standard, window settings 350, window width over 50, window level, soft tissue 1500, window width over 700, window level lung. For 16 detector protocol, we are using gantry rotation time 0.8 second, 64 detector protocol 0.8 seconds, acquisitions detector width times number of detector rows is equal to detector coverage. 16 by 1.25 is equal to 20 millimeter in 16 detector protocols. 64 detector protocols is 64 by 0.625 is equal to 40 millimeter. Reconstructions or slice thickness over interval. In 16 detector, 2.5 millimeter over 1.25. In 64 detector, 2.5 millimeter over 1.25. Pitch, 1.375. Same in 64 detector, 1.375. Kilo voltage peak, 120. In 16 and 64, same, 120. Milliampere. Auto minute 100 for maximum 150. Noise index 15. Auto minimum 100 for maximum 150. Noise index 15. Okay, that's all for today. I hope you gained some knowledge in this video. Hope you like it. Please like and subscribe for more updates and topics. Thank you for watching.